right, good afternoon, everyone. We are going to go ahead and get started. Allow me to welcome you all to the third part of our web series, which is Healthcare and Public Health Planning for Radiological and Nuclear Emergencies. The title of today's presentation is going to be Pre-Hospital Setting and Community Reception Centers, Some Pearls of Wisdom for Safe and Effective Assessment of Victims of a Radiological Emergency. Next slide, please. So we are one part of the Regional Disaster Healthcare Response System. We are actually the fourth region that has been funded by Health and Human Services with the Administration for Strategic Preparedness and Response. So notice kind of our goals here as part of the Southern Regional Disaster Response System. Our ultimate goal is to complement existing preparedness and response frameworks. That's very important. We're not looking to take over anything. We're just trying to figure out how we complement the existing resources that are available to the healthcare community. We do that in a couple of ways by providing clinical subject matter expertise, in addition to healthcare system operational expertise and how those get integrated into the existing preparedness infrastructures. Next slide, please. So we do this, we are a consortium of a group of people or a group of organizations. So our primary leads are Emory University, who ultimately has the contract. And then we have three additional groups that are a part of this. So we have Augusta University Health System, we have the University of Georgia's Institute for Disaster Management, and the Georgia Department of Public Health. But one thing that's really important to point out is although these are the leads of the overall Southern Regional Disaster Response System, this is ultimately a consortium of organizations. And you can see many of them listed out to the side. So we're constantly soliciting expertise from all of these different groups so that we can complement these existing healthcare infrastructures. Next slide, please. So as part of this series, though, we also have partners that are specific to this webinar series who are providing subject matter expertise in addition to people who are actually presenting on the webinar series. So we'd like to make special mention of them. We have the American College of Medical Toxicology. We have the Association of Healthcare Emergency Preparedness Professionals. We have the Radiation Injury Treatment Network, the Interstate Disaster Medical Collaborative, and the Region 4 Poison Center collaboration. And you can see all of the entities that make up the Region 4 collaboration there. Next slide, please. So as part of this webinar, I think one of the things that we get some of the most information out of is the question and answer session. So within your Zoom platform, you have a button down at the bottom that says Q&A. That's the area where we're going to ask you to submit all of your questions in. A couple of things that we'll ask. Number one is don't wait to the end to submit your questions. So as the speakers are talking, if you come up with questions that you have, please go ahead and submit those. And at the end of the webinar, we're going to try to answer as many of those as possible. Next slide, please. We also offer continuing education credits as a part of this webinar series. So through the Emory Nursing Professional Development Center, we do have one continuing education credit for nurses. A couple of things to make note of, though, is to be sure that you are staying for the entire webinar. So there's certain times, like if you get up, you have to leave for more than 10 minutes, you do not actually get full credit. The other thing to mention too is that at the end of this webinar, there's going to be an evaluation survey that's going to pop up. So please make sure that you fill that out. If you don't, tomorrow we will email all the participants a follow-up survey. You only need to fill the survey out one time, okay? I can't overemphasize that enough. Please don't fill it out both times. Either do it at the end of the webinar or do it tomorrow when we email it out. Also through the Emory University School of Medicine, we are offering also one continuing medical education credit for that as well. Next slide, please. So in addition to that, we do have some pre-hospital CEUs that are pending. So stay tuned for that, and we'll email out more information to the participants if you are needing pre-hospital CEUs. So we're still currently working on some of that right now, so please stay tuned for that. Next slide, please. So my name is Dr. Kurt Harris. I'm the director of the Institute for Disaster Management at the University of Georgia. I'm also an associate professor within the College of Public Health and serve as the Southern Regional Disaster Response System Executive Director. My co-moderator for this entire series is Dr. Isakov, who's an emergency medicine physician and medical toxicologist at Emory University. And he's also the Associate Medical Director for the Poison Center and the Associate Medical Director for the Southern Regional Disaster Response System. Next slide, please. Today, we also have two co-moderators with us. So we have Dr. Alex Isakov, who is a professor of emergency medicine and executive director of the Office of Critical Event Preparedness and Response and director of the section of pre-hospital and disaster medicine at Emory University. And he's also the principal investigator for the Southern Regional Disaster Response System. In addition, we have Mr. Sam Shartar, who's the Senior Director of Operations of the Office of Critical Event Preparedness and Response and the Director of Emory EMS at Emory University. Next slide, please. Now let's move into our speakers for today. So we have two speakers for today. We have Mr. Jim Hardeman and Mr. Keith Wages. So we'll start with Mr. Hardeman. So first thing to note is Mr. Hardeman is retired, right? Something I think that we're all trying to get to at some point in our careers. So he is retired, but he is back helping out on this webinar series. So after serving for more than 30 years as the manager of the Environmental Radiation Program in the Georgia Department of Natural Resources Environmental Protection Division, where he was responsible for directing the state's efforts in environmental monitoring around nuclear facilities and radiological emergency response. Jim served as the state's radiological emergency coordinator, developing protective actions and recommendations for the governor or his authorized representatives, and working with the Federal Radiological Monitoring and Assessment Center Radiological Assistant Program personnel, the advisory team on the environment and food and health, and other federal responders upon their activation. In this capacity, Jim participated in more than 50 federally evaluated radiological emergency preparedness exercises at commercial and defense-related nuclear facilities, and was called upon to evaluate federal radiological monitoring and assessment center performance at national level exercises, including the August 2007 Topol 4 exercise in Portland and the May 2009 Empire exercise in Albany. Jim is the former chair of the Conference of Radiation Control Program, Director's Emergency Response Planning Committee, and currently serves as an advisor on this committee. Jim is also a live member of the Conference of Radiation Control Program Directors. Jim spent 3 years overseeing the cleanup of radiation sterilizers, Incorporated cesium capsule leak in Decatur, Georgia. Jim also provided on-scene oversight at one of the nation's first Superfund cleanups in 1982 at the Luminous Process Radium Watchdial plant in Athens, Georgia. Jim is a volunteer type 2 radiological operations support specialist and provides consulting services related to radiological emergency response. In addition to Jim, we also have Mr. Keith Wages, who's the Associate Program Director for the Southern Regional Disaster Response System at Emory University School of Medicine. With 45 years experience in planning, delivering, and managing emergency medical services, public health, emergency management, and homeland security programs at local, regional, state, national, international levels, Keith retired as the director of the Georgia Office of EMS and Trauma in 2019. During his time as the state EMS director, Keith was president of the National Association of State EMS Officials, chair of the Joint National EMS Leadership Forum, and a member of the Interstate Commission for EMS Personnel Practice. He has also held positions as the division director of state and local programs for an international emergency management and homeland security firm, executive director of the Minnesota EMS Regulatory Board, director of the planning for the Georgia Emergency Management and Homeland Security Agency, regional EMS director for Northeast Georgia, and EMS director for Walton Regional Medical Center. Through the governor's office, Keith also served as a medical coordinator for the 1996 Olympic Games in Atlanta. So as you can see, we have a tremendous amount of expertise to discuss the topics that we have today. So with that, Mr. Hardeman, I'm going to turn it over to you, sir.
Well, good afternoon, folks. Like I said, I'm Jim Hardeman. I wanted to thank Emory University, in particular the Office of Critical Event Preparedness and Response, for allowing us to use their EOC today. Keith and Ziad are here with me, as you can see. So it's going to be kind of a panel presentation today. So we may be a little bit more interactive than some of the earlier ones. I'm going to go back and do a brief radiation refresher. I don't have a good handle on who the audience is today, so I want to make sure that we're bringing everybody up to a common level. Radiation is all around us. It is energy being transmitted. All of us have a phone on us right now, I assume. And so there's radiation being emitted and being received by that phone in the terms of radio waves. The radiation that we're going to be talking about today is ionizing radiation, radiation that has enough energy that it can actually kick electrons off of atoms. If you're talking electromagnetic radiation, we're talking X-rays and gamma rays, primarily gamma rays. Next slide, please, Leo. We can also we'll be dealing with particulate radiation, in particular alpha and beta particles. One thing about gamma rays is they almost never occur by themselves. They're usually accompanied by the emission of a beta particle. And a beta particle, for all intents and purposes, is an electron. It just happens to be emitted from the nucleus of an atom, but it looks exactly the same as an electron. It has a slight negative charge, and that electric charge can be used to detect it, but it also can do damage to the human body. An alpha particle is essentially a helium nucleus. It is 2 protons, 2 neutrons. In nuclear terms, it's a very heavy, very slow moving particle. It has a very short range. As we'll see in the next slide, it can be easily shielded. There's also a mention on this slide about neutrons. We're not going to talk much about neutrons today. You very rarely are going to see neutrons in the wild unless you're dealing with certain industrial sources like moisture density gauges that do have small neutron sources associated with them. But otherwise, the only time you would deal with neutrons is if you were, say, at an incident involving a nuclear plant actually in the plant. May next slide, please.
Now, Jim, as you comment on that, before we move to the next slide, this ionizing radiation,
Yeah.
where does it come from in the environment? Why is it emitted?
Well, in the environment, I mean, it's everywhere. It's in the soil. It's even in our bodies. We have a radionuclide in our body, potassium 40. It's a primordial radionuclide. It has a very long half-life, but because it's potassium, every time we have it in our bodies, we could actually, if I could sit you in front of a radiation detector, I could come within a few pounds of guessing your weight just by the amount of potassium 40 that you have in your body. Building materials, you name it. I mean, you go dig up some dirt in your yard, there's going to be some uranium in it. So it's everywhere.
Thank you.
It's everywhere. Talking about the different types of radiation, let's start with alpha. Alpha particles can be easily shielded. They don't penetrate the dead layer of the skin in the human body. They're stopped by a sheet of paper. The downside to that is if you get an alpha emitter inside the body, it can be extremely dangerous. Some of these alpha emitters, let's use radium-226 for an example. They seek certain organs. They'll go to bones, or they'll go to the liver, or whatever. So wherever they go, they can deliver an enormous amount of energy over a very small area. Beta particles are a little more energetic, have a little bit more range. Probably the best shield that is going to be available, particularly in the field for beta particles, is going to be plastic. Those of you who are familiar with nuclear medicine programs and hospitals, you'll notice that in their hot lab, they've got plastic shields in there to shield the beta particles. If you get a beta emitter, a large amount of a beta emitter on the skin, it can cause burns that are similar in appearance to a sunburn. So you want to keep it off of the body. I mean, that's the whole point about having protective clothing, is to keep those beta emitters off of the skin. Gamma radiation is penetrating radiation. Protective clothing is not going to stop gamma radiation. It doesn't help in terms of reducing radiation dose. So gamma radiation, we're going to talk about in a little while. There are a few ways that you can protect yourself from that, but any of the protective clothing, gloves, boots, masks, that kind of stuff that you're going to have, that's not really protecting you from gamma radiation.
You know, here, Jim, I want to just remind everyone, and I've seen this people in different plans or discussions. The alpha and the beta particles are not going to contaminate the person. That often people think of them as, do we say particles? They think of them as solids that can contaminate someone's body or clothes. It's the material that contaminates
Right.
the body and the clothes, emitting a beta particle.
Right, it's a chemical substance, an element. It's cesium-137, for example, is one that is pretty common. The material itself, I mean, it's, you know, it's a solid. It looks kind of like a table salt. And it is emitting those beta particles, and it's also emitting gamma radiation. So that's, I appreciate you bringing that up, because that is, you're not contaminating it with the particles, you're contaminating it with the material that is emitting the particles.
And Mr. Alexander Litvinenko, who ingested polonium-210, which only emits alpha particles, died about 2 weeks later, because that what you just said, these alpha particles
Right.
were released from the polonium inside the body near sensitive organs and led to the organ damage.
Yeah, interesting thing about that story, there is a gamma that is emitted very infrequently from the decay of polonium-210, but it was actually that gamma that enabled the detection of the polonium-210 in Mr. Litvinenko's urine. And of course, unfortunately, that detection occurred concurrent with his death. So they really didn't know that he was contaminated with radioactive materials until essentially the day he died. And that's gonna be important later on when we talk about protective clothing. Yeah, next slide. So where are you going to run into radioactive materials, particularly if you're talking about, you know, from a medical response situation? Well, the big one from an accidental standpoint is transportation, where you will have, there are radioactive materials in transit in this country all the time. If we go to the Atlanta airport at 2 o'clock this morning, 2 o'clock tomorrow morning, there are probably jets that are flying in, cargo jets that have radioactive materials in them. They're radioactive material, particularly on a Monday morning, where pharmaceuticals are being shipped. And then they're in turn taken from the Atlanta airport to hospitals around the area. So there are radioactive materials being transported all the time. And sometimes those vehicles get involved in traffic accidents. In my career, there were, you know, maybe half a dozen of them that we had to deal with in various capacities. Industrial incidents. One of the big industrial areas that you might see is the scrap metal processing industry, where we had radioactive material sources that would get entrained in scrap metal. And if someone were to be injured while dealing with that scrap metal, it's entirely possible that they could get radioactive materials on them. There are other industrial sources. The radioactive materials are used for gauging applications in a number of industries, things that you wouldn't think about, paper industry, you know, all sorts of things. So anytime that you want to measure the level or the thickness of something in an industrial facility, radioactive materials may come into play there. Nuclear power, where you might see this, and this is an interesting one, is you might see someone get radioactive materials on them, assuming that there is a release, which is pretty unlikely, in the process of evacuating from an area. They may get involved again in a transportation accident or something like that. It's interesting to note here that the medical facilities, hospitals, and EMS providers in the general area, roughly 10 miles around the nuclear plants in the country, are required to go through training on how to deal with radioactively contaminated patients. And not only are they required to go through this training, but they're actually evaluated on their capability to handle contaminated patients without, contaminating themselves, contaminating the ambulance, contaminating the emergency room, that kind of thing. So they're going through that training all the time. Obviously, there are malicious incidents. We've talked about these in previous sessions. Those who were around for the first couple of classes here, we talked about improvised nuclear devices, where you're talking about an area of impact that's easily over a kilometer, and depending on whether it's a ground burst or whether it's an elevated burst, you may have fallout, dangerous levels of fallout that go tens of kilometers downwind. So you've got a large area and potentially a large number of patients that are contaminated with radioactive materials and dealing with that incident. Radiological dispersal device is a smaller device. It's not a nuclear explosive. It's a conventional explosive that happens to have a radioactive material associated with it. My classic example, one that Ziad and I have used before, is cesium-137, and a few pounds of some explosive, be it TNT or a plastic explosive or something like that. And there you might be talking about maybe 100 meters. I think some of the guidance is that you would want to set up a perimeter at 500 meters, but that again would depend on the size of the explosion that you're talking about. So, but you could have you'll have a smaller number of patients in the immediate area of the explosion. Their big impact is going to be the impact of the explosion themselves, and they may have pieces of the device impaled in their bodies, and we'll talk about that a little bit later too. Radiological exposure device is simply a radioactive source that is placed somewhere with the intent of delivering a radiation dose to a person. I guess the intent would be to deliver a large enough radiation dose to that person that they would develop acute radiation syndrome and ultimately die. Where you would not expect to see any contamination, any radioactive contamination associated with this, but again, depending on the nature of the incident, every incident is different. If somehow or another this device were to be damaged, it's possible that there could be contamination associated with it. Next slide, please.
Before we get to the next slide,
Okay.
I just want to pause here for 1 second. So the improvised nuclear device is clearly a scenario where responders, and again, today we're focusing our webinar on our responder community, commercial responders. Are there areas where they need to, these are scenarios where they will be looking for radiation, right? I mean, there's an explosion, there's maybe a mushroom cloud.
Right.
So they will be, looking for radioactive material in most of their protocols. Is that correct, Keith? Maybe you can comment on that in terms of EMS SOPs.
Well, certainly, and one of our primary concerns, particularly with radiation, is having an event that cannot be immediately recognized by the EMS personnel.
Right.
So our worst case scenario would be for the EMS personnel to be exposed, contaminate the ambulance by placing the patient in it, and then obviously ultimately taking the patient to a hospital and potentially contaminating that. So early recognition is critical in effectively managing this, and that's I think Jim's going to put us in a better spot to do that as we go through the day.
I hope so. Going back, you were mentioning the IND. I mean, obviously, I think Bob Whitcomb talked about this in one of the earlier sections, that there are areas that immediately adjacent to ground zero where you really don't want responders to go, because they will be receiving potentially lethal radiation doses going into what's called the heavy damage area. So that's a whole different topic that we could spend, several of these seminars talking about. the medical response or the overall response to INDs. In fact, several of us are working on a 3-day course about that right now. So anyway,
Can I ask you a
excellent.
question?
Yeah, you sure can.
Jim, this is Alex, and I'm asking a bit in part responding to questions that are coming through the Q&A channel. But
Okay,
let me try to weave a couple things together. You'd said earlier that there's sources of radioactivity all around us. There was a question about what you meant exactly by that. That's part one. Part two is that I think we would all presume that if first responders actually have access to a detection device for, to determine risks of radioactive sources on the scene, that they would be able to distinguish a reading that was abnormal from readings that they would get simply because there's background radioactivity. So can you address maybe the first point, which is that there's radioactivity all around us, and two, how do we distinguish background activity from activity that would pose a risk to responders?
Yeah, those are both good questions. Yes, what I meant by my comment was that, yes, there is a background level of radiation that exists everywhere. And you can take radiation detection instruments, and particularly some of the more sensitive ones, and you can detect that background radiation. And it varies from place to place. And that's one thing that we tell people when they go to a response, turn your instruments on a long time before you get there so that you have an idea of what background radiation level is on your instrument. And that kind of leads me into answering the second question, is that many of the instruments, and I'll use the RADI instruments that the state of Georgia purchased these many years ago. You can set alarms on those instruments. You can set, for example, if you want to say a radiation area is 2 millirem per hour and anything under that you don't want to really worry about, then you can set an alarm on that instrument so that when you reach that radiation level, that instrument will let you know, okay, I'm seeing something abnormal here. I'm seeing something above natural background. Now, if the instruments that the particular organization is using don't have that alarm capability, then it really comes down to being a training issue and training and capability maintenance issue. How do I use this instrument? How do I use it effectively? When is it reading background radiation? When is it reading something that's more significant? That get your question?
So, Jim, can I add on to that for just a second too?
Sure.
So one of the things that I think is really important also is not every detection device is created equal. So some of them have scales on them. And so if you don't have them set to the right scale, or if they're not calibrated appropriately, it can actually look like there's either tremendous amount of radiation when there's not, or there's very little radiation when there's actually a lot to be viewed. So understanding what type of instrumentation you have, because some of them don't read beta radiation or alphas, they may only read gammas. So knowing what type of instrumentation you have, knowing it's calibrated, and understanding the settings are really important as well.
Kurt, you led me right into the next part of the presentation, brother, and I appreciate that. I'll give you an example. Some of the instruments that we use, like these RADI instruments, there are some that are extraordinarily sensitive, and they're meant for a search team, for example, to be looking for illicit radioactive materials. So they're very, very sensitive. And if you turn the audio on, for example, you'll think, oh my God, I'm in this tremendous radiation field, when I'm not. The other side of the coin is some of the old CDV instruments.
Civil defense.
The civil defense instruments, particularly the ones that were actually designed for use in wartime. You'll never see background radiation on those instruments because the instrument is designed to read higher levels of radiation. You'll never see those. The two instruments that, and I'll preface this by saying, I have long been a proponent of emergency responders, first responders, police, fire, EMS. I've long been a proponent of those people having access to radiation detection equipment. Ideally, having some on each piece of rolling stock, but I know that that's an expensive proposition. For detecting contamination on people, particularly beta, although you might be able to see some alpha contamination on these instruments, the ideal instrument to be used is a pancake style Geiger Muir detector,
Right.
or a Geiger counter. And you've got two different examples on the screen here. One is an instrument body and a cable and a pancake detector. And then the other one is kind of a self-contained unit, these rad eyes, where you've got the instrument body and the detector together. And these are very sensitive to beta radiation. They will also respond to gamma. And if this is the only instrument that you have, you can actually use it as a means of detecting gamma radiation, maybe not so much measuring it, but at least detecting that there is gamma radiation present. And again, that's a training issue on teaching people how to use these instruments.
So you would use this to look for ejected material on people's bodies or on the ground, somewhere where you're in,
Yeah.
on the scene?
Yeah, I wouldn't necessarily expect an EMS crew to do a whole bunch of that. Keith, maybe you can weigh in on that. I would expect this to be more something that would happen in the ER. I guess there are situations where an EMS crew might do that.
It would be a relatively rare circumstance for one of our pre-hospital providers to be making that sort of an evaluation.
Right.
I think that would be done either by either at the hospital or potentially by a fire department or someone with particular expertise in that area.
Right.
But it would be a rare occasion for EMS to do.
Yeah, I think what you're going to find in your pre-hospital situation is you're going to find perhaps do a gross decon. We'll talk about that in a few minutes. And then basically wrapping the patient up to prevent the spread of contamination, and then transport them to the EMS or to transport them to ER. And of course, notify, and that's something that I think Keith will talk about.
Sure. Anytime we're treating, responding to a serious illness or injury, there's 3 or 4 things we'd like to do on every call. We want to assess the patient correctly. We want to transport the patient to the correct hospital, depending on the circumstances and the patient's condition. And it is very important that we notify the hospital that we are en route and with what our observations are. And it wouldn't matter if we were talking about a stroke patient or a cardiac patient, or in this case, a patient with radiation injuries. But it is very important that we notify that we pick the right hospital and notify the hospital that we're on the way.
But of course, for this to happen, Keith, you need to recognize, and I know we talked about the mushroom cloud or the explosion, but what about this gamma radiation, detector, the ionization chamber? Wouldn't that be something that will help the paramedics or to the fire department or the hazmat team that may have this ionization chamber, this gamma detector, be able to detect the risk on the scene?
If there is a gamma emitter present, for example, let's use cesium-137 again as an example. If there's a gamma emitter present, a gamma detector like the ion chamber or this GM detector or similar instruments will tell them that there's a hazard. You probably wouldn't use this instrument to tell whether a particular patient was contaminated, but you would certainly use this instrument to say, I've got a radiation incident. I'm involved in responding to a radiation incident. And that may be the information that the hospital needs, not necessarily that this patient is contaminated, but potentially could be because I'm dealing with this radiation incident.
Well, looking at Sam or Alex or Keith, do our EMS agencies have SOPs to look for radiation on a scene?
I would say those sorts of SOPs would be more common in a fire service environment, potentially following an explosion. I think the protocol to look for that just on a typical call from the EMS community, I don't think that would be the case. But in some departments where that equipment is available, after any explosion, they would use the detection equipment to rule out radiation's presence.
Right.
Which one would you use, Jim, if you had a magic wand, and which detector would you use to go and look for?
This RAD-IG there on the left side of the screen is and I'm not doing this to make a commercial for any particular instrument manufacturer, but what I'm saying is that instrument or a similar instrument is something that I have long been a proponent of putting on every piece of rolling stock, just so that they'll know that there is an above background level of radiation present that may be dealing with a radiation incident. Otherwise, you're stuck with looking for a radioactive placard on a truck or something like that to give you a clue that there might be radiation present there.
Well, what about their own safety, the first responders' safety? Do they need to wear a dosimeter? How does that work?
They probably don't, actually, and I know this is probably some people may not like this, but the likelihood is that these responders are not going to be dealing with the amount of radiation that would be hazardous to them. The exception to that, obviously, is the improvised nuclear device scenario, where there's going to be an enormous amount of radioactive material present. Whether there are enough dosimeters to service the emergency response community, I really don't know. But in the normal course of business, I don't think dosimeters would be called for. Obviously, there are incidents, the one in a million, 1 in 100,000 that might be advisable. We'll talk about one of those incidents in a minute.
So this is Alex, and I think that this is really a critically important question for the EMS community and anybody tuning in to this conversation, which is how does dosimetry change the emergency first response or the emergency medical response? We know that, and let's steer away from the improvised nuclear device, which is fairly unique.
Right.
And maybe even steer away from a nuclear reactor disaster,
Right.
where EMS agencies that are in the immediate vicinity of those types of facilities have some special training. But maybe what we're concerned about here is that EMS agencies in cities all over this country have some risk of encountering a dirty bomb, Jim, as you described, a radiological dispersion device.
Right.
And if the SOP by the fire first response service actually is to detect if there's greater than background presence of greater than background radiation, how does it change the response? I would say at a very high level, and we can talk about it more, patients are going to get assessed. They're going to get their primary and secondary survey. There's going to be some triage of patients. Life-saving interventions are going to be rendered. And then there's going to be some decision about transporting patients from the scene. I think if we knew that there was a risk of a radiation hazard after a radiological dispersion device detonation, we would want to take some measures to better protect EMS personnel responding to that event by advising them on the use of respiratory protection, an N95 respirator if better, or better if you have it. Some kind of garment protection, even if it's a coverall or a gown or something to maybe protect you from particulate contamination. You really, as you've discussed, alpha and beta emitters are most dangerous if they're inhaled or if they're ingested. That could go for gamma emitters too. So preventing people from eating, drinking, inhaling radioactive particles is paramount. But we also don't want to have the EMS community paralyzed by the prospect of there being radioactivity on the scene.
Right.
The conventional wisdom is that after an RDD, while radioactive particles are present, they're likely not going to be at a high enough level that would cause be a real health risk to emergency responders. And so it's still important to do those primary and secondary surveys and initiate life-saving interventions. And then some of the considerations are taking appropriate action as it relates to application of elements of or parts of a PPE ensemble. And frankly, if patients are not significantly injured, if they're minimally injured, then perhaps not rushing to transport them to hospitals and kind of spreading the risk of contamination to other locations, but
Right.
rather keep the minimally injured in a safe place on scene, where then there can be some determination about their need for decontamination prior to transport.
Yeah, you could set up some kind of alternative treatment, near site. I think that would be a wise thing. Once again, you led me into my next slide, and let's move on to that one because we're kind of running short of time. We're going to talk about PPE a little bit. The first picture there, I think, depicts what most EMS providers are going to have readily available. They're going to have a mask, maybe not an N95, maybe something a little less than an N95, and they're going to have gloves. The middle picture there is standard precautions, where you've got gloves, you've got a gown of some sort, you've got a mask, you've got eye covering, and then you start getting into the heavier levels of protective equipment. And here we've got, Tyvek and a PAPR. If you want to go the nuclear detonation route, you could go all the way up to level A. The good thing I want to talk about Mr. Litvinenko here. We talked about the fact that you had a patient who had ingested several times the amount of radioactive material required to kill him. And he was being treated hands-on by 40 or 50 medical personnel for, I think it was 23 days, actually. I think it was like 3 weeks before they even knew that he had radioactive material in him. And he had radioactive material in all of his bodily fluids, his sweat, his urine, everything. And after this incident, and I know our CDC friends can fill us in more on this because they were involved in some of this, but there was a lot of testing of the medical personnel who provided care to this gentleman. And yes, there were some intakes of radioactive material, but they were all minimal. I mean, they were detectable, but they were not nearly enough to cause harm to these people. And that goes back to my first slide about radiation being everywhere. Is just because you can detect it, that doesn't mean it's bad. Doesn't mean that it's bad for you. So I'll leave it at that. Standard precautions work. Obviously, if you're providing services closer to the scene of an incident, then you may want to have heavier protective clothing. I don't know that EMS providers are going to be in a position to do that. Is that a good statement, Keith?
Yeah, I agree completely. We talk within the EMS community all the time about how we maintain competency in low frequency, high criticality events. And very few things would personify that sort of an event more than a radiological emergency. So we want to do the things that we do all the time. We want to train, we want to have continuing education, we want to exercise as appropriate, and have protocols that guide us through these low frequency, high criticality events. And of course, the EMS, on behalf of the EMS community, we're so grateful to the work that Jim and Zion do, not only today, but for throughout the year in preparing the EMS community for these sorts of events.
I want to just point out a couple of things though here, just to make sure that, you know, we all remember that if you're on the scene, if you look at OSHA standards, they are going to recommend an air purifying respirator for respiratory protection.
Right.
But if you look at some of the other expert agencies like the National Council on Radiation Protection and Measurements, look at the Radiation Emergency Assistance Center Training Site, REACTS, or the CDC, you see them, offering other options as well, considering the resources and the situation. So if you are in a scene where there's a lot of suspended debris that's potentially respirable, it is wise to look for your air purifying respirator. But if you are in the emergency department where maybe 2 or 3 hours have elapsed since the patient was in the scene, the likelihood of debris on their body, creating secondary clouds of debris in your emergency department, requiring you to be in an air purifying respirator, especially after decontamination, is on that. This is why the NCRP recently published a statement on that, saying that still look for an APR. If you don't have an APR, get an N95. You don't have an N95, a surgical mask, or a face covering, depending on, but don't paralyze your response on that account. Going back to the dosimeter question, Jim, I know we're short on time, but I want to just say one thing. You know, I think I would say more that dosimeters are desired if we had them, if the responders is on the scene.
Absolutely, but I wouldn't want to hinder a response
Agreed.
because somebody was waiting for
Agreed.
a dosimeter.
But I wanted to add that you could potentially get this data later. I mean, the doses people have received during a response could be calculated by the environmental sampling, the air sampling that you'll do, and then maybe a few people get surveyed or you can have a group dosimeter, several people with one dosimeter potentially in one response. So I just want to remind.
Let's move on because we are running short on time here. This is one of the most important slides that I think I'm going to show today, particularly for an EMS provider. And this is one of the most important things that you can do is to go out there and double glove. That way, if you're dealing with the patient directly, you contaminate that outer glove, you can remove it, get another one. Hopefully you're not going to actually contaminate yourself. And I don't think anybody is going to criticize a responder for the fact that they went through 10 or 15 pair of gloves on an incident involving radioactive contamination. So just leave it at that. Again, a lot of contamination is not going to be done in the field. These the third and fourth bullets there are important. If there is a lot of loose radioactive contamination around, or it appears that there is, oftentimes you can reduce that tremendously simply by removing the outer clothing. There are techniques to do that. We're not going to go into that today. Kazi and I have courses on that. But that and being able to wrap a patient up and wrap them up in sheets, don't put them in a body bag. That's not a good idea, sends the wrong message. But wrap them up in sheets. And then you can place them on a gurney, on a backboard, put them in an ambulance and transport them. And the probability of contaminating that ambulance is minimal. This is an important point too, that, shouldn't delay the delivery of life-saving care to a patient. Somebody's having a heart attack, somebody's got a, sucking chest wound or something like that, and they're potentially contaminated by radioactive materials, deal with the injury that is life-saving. You can always decontaminate them later. You can always decontaminate yourself later. And I know that this is counter to some of the training in other disciplines, for example, the hazardous material discipline, that this is counter to some of the training there, where the material that's on the patient there can be a hazard to the treating medical personnel. So this is this is one that when I was delivering these trainings, even in my illustrious career with the state of Georgia, we would get a lot of pushback on this from the medical community. But, you know, this is a message that we've been trying to get across for a long time.
And of course, I usually use the example of the Goiânia incident where it had cesium-137, 249 people were contaminated externally or internally, or both. They were also cared for by healthcare providers. Initially, it was unknown for about a week what was going on,
Right.
and no healthcare provider was affected. Same
Right.
with Chernobyl.
Right.
And I think you can use some simple techniques like time, distance, and
Time,
shielding.
distance, and shielding, amazing, yeah.
So can I interrupt for a minute? There's a very important question in chat, I think, and that is knowing and drawing from a lot of discussion that's already taken place, may not recognize it's a radiological event or that critical patients are transported to an ER. There's a question on the board about how should ER personnel most appropriately decontaminate patients that they receive who are critically ill. And another question, again, reinforcing the PPE profile posture. You've
Well,
already-
we got about 5 minutes. I don't know that we can respond to
Well, I'm
that
gonna just
question.
ask people if they're interested. We're gonna try to stay an extra 10 minutes.
Oh, yeah, we can stay on for a while.
But this is recorded.
So you're talking about a patient that was transported to an ER that at the scene and even until when they get to the ER, they do not recognize that they've got radioactive contamination. And only when the patient is in the ER do they recognize that. Is that?
Well, they
is
know
that
they're
the gist of the
contaminated.
question?
They know they're contaminated. They're transported because they needed to bypass because they were seriously ill. The question was how to decontaminate in the ER.
Oh, okay. Boy, that's going to be very situation dependent. The hospital may have some procedures for preparing an ER for other situations that might present a similar hazard. Some sort of infectious disease protocol or something like that, where they're bringing somebody into an ER. Again, the primary, I think the thing for the ER, the emphasis is going to be care for the patient and do as much as you can to prevent the spread of contamination. And that's going to be, you know, transport the patient as little as possible inside the hospital. If you've got a room that opens directly to the outside, use that. You can use, you know, plastic and sheets and drapes. You want to minimize the number of people that you have coming in and out. Once somebody is in the treatment area, you know, don't have them go back out and potentially spread contamination. I mean, there are ways that can happen. It's hard for me to answer that question in a few minutes without having, you know, some scenario in mind there.
I would add to this, Sam, that, you know, I would use distance. So any evaluation of the patient that can be done at a distance. Remember, the dose we receive from evaluating somebody who's contaminated with a gamma emitter is inversely proportional to the distance that separates me from that material. And that's the inverse square law. And it's very powerful. And we've done some of that in COVID, where we would try to get information about the patient from the door initially before we don the PPE and get our exam. The other thing we could do is time. If a procedure requires an hour in the operating room and the person is contaminated, maybe having 2 surgeons divide up or 4 surgeons divide up the procedure.
Right.
That will also decrease the dose. Unfortunately, shielding with lead aprons is not sufficient.
Usually not going to be effective in any kind of hospital setting.
But those are some of the techniques that I would follow. And I would definitely bring the patient in as soon as possible in a sheet to decrease the spread of the dirt and the dust on the floor.
Absolutely.
And deal with it later.
Absolutely.
One other piece to that too, Jim, if I can just quickly, is there's a difference between internal and external contamination too. So you can decon them all day. It doesn't mean your detection devices are not still going to pick up radiation.
Absolutely.
The threat to
Absolutely.
the responder is not really that high as long as they're removed from the radiation field. So keep in mind that your threat level to someone who has radiation exposure is not necessarily high because they're no longer where the radiation source is located. But after you decon, you can do it twice and you could still detect radiation. because it's
Right.
internal at that point.
Yeah, and let's go on to the next slide, because this is a perfect example of what you just talked about there. In particularly in the explosive situation, you may have shrapnel. That shrapnel may be, because of its very nature, radioactive, or it may be contaminated with radioactive material and may get impaled in the body, and you can decontaminate all day long. And until you remove that source from the body, you're still going to be able to detect it. So again, medical personnel, time distance shielding, use of forceps, that's kind of a no-brainer for medical personnel. You're not going to be grabbing at something like this with your fingers anyway. And again, we've kind of gotten away from the pre-hospital setting here, in that, I don't think an EMS crew is going to be trying to pull shrapnel out of people's arms. What they're going to be doing is bandaging it to try to stop the bleeding, which is going to keep the that in and by itself is going to keep radioactive material from spreading, or at least it should. Next slide, please. And again, this is what we were talking about a minute ago, about transporting the patients. There are techniques using 2 sheets where you can basically, cover the backboard or cover the gurney with the sheets, put the patient on there, and then wrap the patient up in those sheets. And then that way you can, in a sense, cocoon the patient inside those sheets and prevent, or at least minimize, I don't want to say prevent, the spread of radioactive contamination from that patient onto the ambulance, onto the driveway of the hospital, or the ER, or any of that kind of stuff.
Any special cleaning procedures for the ambulance between patients?
Again, that's situation dependent. If you're talking about, particularly if you're talking about a major incident where you've got a number of patients and you're going to be going back in to pick up patients who are also potentially radioactively contaminated, then I would say no, that you're not going to be decontaminated. If it's a onesies, twosies situation and there's a potential that the ambulance has been contaminated with radioactive materials, I know that there are procedures, particularly in the infectious disease world, for decontaminating ambulances. The techniques would be very similar in decontaminating an ambulance with radioactive materials. The advantage in decontaminating an ambulance that has radioactive materials in it is that can be detected. You can tell when you've got it clean. Where with the infectious disease world, you don't know. You just
So you can get it back to clean.
Hmm?
You can get it back. to
You
clean.
can, yeah. I mean, ambulances are designed to be decontaminated.
Especially with a helicopter in mind.
Yeah, I have a helicopter story, but we don't have time to tell it right now. So let's move on. We're going to change subjects abruptly here. And this was because I was asked to talk about reception centers. I've only got 1 slide, so we can talk about this, and then we have a few minutes left for questions. In a large radiation incident, particularly in urban areas, let's talk about Metro Atlanta. You might be talking about Cobb or Fulton or DeKalb counties. At some point, if there are enough people involved in this incident who might be contaminated, or that there are enough people out there who want to be decontaminated or want to be assessed, then they might stand up something called a community reception center. I'll give you an example. Kazi talked about Goiânia a minute ago. They said that, yeah, they detected 249 people who had radioactive contamination on them. But my recollection is they had to survey 125,000 people to find those 249. Correct. Now they did not have a center like this. Yeah, well, they made several actually. But the idea here is that you have a central location that you can bring people to, where you can screen them for radioactive contamination, and there are ways of doing that. Hopefully you're not using the instruments I showed earlier, but you're using something like a portal radiation monitor, where you can assess a large number of people quickly. You can decontaminate these people if that is required. The interface between the pre-hospital setting and the community reception center is that these CRCs usually have associated with them a first aid station. So, you know, if somebody's waiting to be assessed and they have a heart attack, or they go into, you know, diabetic coma, or, you know, I mean, whatever, you know, think of whatever first aid situation you might have, then they can be treated there, stabilized there, and then they would be available to be transported to a medical facility. But they may not have been, they probably hadn't been screened yet. So you don't know if they have radioactive contamination on them or not. And then if it's again a large radiation incident, you probably want to register these people so that you can follow up after the fact. You know, where were you? How long were you there? That kind of stuff. CDC, you notice the CDC logo on the slide there. CDC has resources. Adela talked about them last month. On their CDC has resources on their website, have all sorts of tools related to community reception centers. I'm certainly not the expert. I've been there when a couple of CRCs were set up. I've participated in them, but you're not going to see them in a transportation accident or something like that. You might see them in a radiological dispersal device scenario, depending on where it is, how large the device is, and how many people were around, that sort of thing. Certainly, you would expect to see them in an improvised nuclear device scenario. Not only close to the scene, you might see them, you know, miles away, maybe hundreds of miles away, in you know, neighboring jurisdictions. So
Jim, do you think it'd be safe to say that in that sort of an event that the health system should prepare for a relatively large number of worried well to deal with?
Absolutely. Absolutely. I don't know that that's the term we use these days. I can't keep up with the terms. I forget what it is, and I'll probably murder it if I try to remember it. So I'll just leave it alone. But yeah, you're gonna have a large number of people who weren't affected, but you know, they saw it on the TV, or you know, heard about it on the radio or something, and they said, well, you know, I might be affected, so I want to go get monitored. That's exactly what happened in Koyanya, where you had a large number of people who heard about this incident through however they heard about it, and said, well, I'm concerned and I want to be monitored.
And after Fukushima, you had about 1 million people got monitored.
Absolutely.
So this is why I added this to this presentation, because I know it is pre-hospital, it is an alternative care site, and it fit in our topic today and wouldn't fit elsewhere in the series. So thank you, Jim, for covering it. I think this is your last slide. Maybe we can take
That was my
questions.
last slide. So if we've got any questions that are just burning on people's minds, we've only got, you know, I don't know how long people can hang here.
We're over the time, but I did want to bring attention to two items that came up in the Q&A. One by Dr. Bueller and one by Dr. Carr. In one case, reminding us that the Poison Center is a great resource.
Absolutely.
And also Dr. Carr's initiative around providing telemedicine capability for EMS agencies in the Georgia community, and how those two resources might assist.
Right. And also I would point out that, you know, last month we had Carol Evans on here from REACT. And certainly if you're talking about a major radiological incident, you know, involving either a large number of patients or a severely injured patient that has some sort of radiation injury, then you've got that asset as well right up the road in Oak Ridge and they're literally no further away than a phone call.
And remember that, yeah, that they actually available for telephonic consultations.
Absolutely.
And poison centers, like Dr. Bueller has mentioned, are preparing for radiation emergencies. They also have protocols and learn this as well during their training to be able to assist, link up between the greater response community, the healthcare providers, with experts like REACTS and the RITN centers. I think all of
Yeah.
that comes together in a nice chain of
And then
response.
as far as poison centers, I know this is going back to a ways for Ziad. But when he was working with the poison center, he and I consulted frequently. And I don't know whether, every poison center has reached out to the state radiation control program to develop that sort of relationship. But it's certainly a good relationship to be established between the state radiation control program and the state poison center.
Absolutely. And I think, going back to the community reception centers, the setup of this is not going to be the first 24 hours
No.
this price. I think it's going to be something that's going to vary from jurisdiction to another, but I think the expectation may be 48 to 72 hours, maybe even 96 hours to get this set up. These are people that are, it's only going to help the response by being a resource for those who want to be checked out. And sometimes, they may be contaminated and required to be washed.
Yeah.
I think, let me see, and I think we've covered all the questions.
Is there
here.
anything else we've got in the Q&A there?
No, I think we've got it done. Thanks everyone for all our panelists, our speakers, our participants, and our organizers. I want to point out to your attention that March 7th at 3:00 Eastern, we are going to tackle number 4 in our webinar series. That is going to be the federal response. So I'm going to talk to our federal partners. We're hosting, Kurt and I, we're hosting Mr. John Richards, who's our EPA, Environmental Protection Agency, radiation response expert for Region 4. We've also invited a representative from the ASPR as well to join us. So we'll bring you some of the resources we have from the federal perspective in the National Radiological Emergency. Thanks again. And remember, this is all recorded and available on the SRDRS website, and soon as well in the Learning Management System classroom, where you can actually log in and take the whole course and get your credit. Thank you and have a great evening. It's very early.
Thank you.
Thank you.